Hi, good afternoon. It's a pleasure to be here. Thank you so much for the invitation. I will move on. I will speak about the Brazilian experience in CML and pregnancy nowadays, and this is my disclosure. I will not repeat what Catarina said to us in a brilliant presentation. Thank you for that. But I would like to think about the challenge that the pregnancy is in our patient. This is a challenge for them. This is a challenge for us, of doctors. And some numbers, we know that 10% of the patients, 10% of the patients, they are in the childbearing age, and they are young women, and the prevalence of leukemia is less than 1 in 10,000 pregnancies. Then we know that the leukemia in pregnant patients is not a problem, because the leukemia is a problem if you are pregnant or not pregnant, and the leukemia is not a problem for the babies. The problem for the babies is the treatment. The treatment with TKI, because as the TKI is an inhibitor of the BCR-ABL, is an inhibitor about these proteins. And these proteins are very important for the formation of the babies and the pertinent to implantation, to fetal maturation. Then this will be the great problem for the patients. Then the great problem, the bigger problem is the treatment. And these are all the adverse events in the pregnancy. Many problems, as Catarina said, and many malformation that you can see if a patient using TKI during the pregnancy. But we know that there are four different scenarios in case of CML in pregnancy. The first scenario, we can see that if the patient that are treating for CML and she unsuspected or not, become pregnant. The second scenario, you can see if a patient, she is pregnant and suddenly she is diagnosed with CML. This is very, very unfortunately. Other scenario is if the patient is the male and his partner, she become pregnant. And the fourth scenario, if a patient that she's a patient with CML and she wish to become pregnant, then we are thinking about how can we prepare this patient to be pregnant. I found this publication that there are some recommendation. Then more ones. I will not repeat that the principle that this is the consensus is stop the TKI. And then in face of a patient with CML and pregnant, or a pregnant that be diagnosed with CML, it is important to stop TKI. If the patient if it's necessary, leukapheresis or interferon, depends on the first trimester, second trimester, or third trimester. If the patient is the male, the man, this is not a great problem. We know that about more than 150 patients, we cannot see any problem in the pregnancy of her partner, and no special safety measure are relevant for male patients receiving TKIs. And if the patient, she wishing to become pregnant, this is our recommendation that you can see. Then you can see if the patient she would like to become pregnant, and she has the criteria to stop the drug. Some things that you need to do is to counseling about the risks, and we can prepare these patients. As Dr. Cortez said, this is important to speak about with the patients in the beginning of the treatment, and then some of patients in the first consultation she asked us, but I never will be pregnant. That this will be impossible to me. In Brazil, you have many patients young female, then they are very, very anxious about the pregnancy, then we can prepare this patient. Then it's important to speak about this, and we know that this will turn this patient more adherent. Then if the patient has the criteria to stop the drug, stop, and if the patients not lose the response, as okay, the observation, but is lose the response, you can treat, depends on the trimester. But if the patients are not, she is not, has not criteria to stop the drug, and her age is perhaps not so young, we can collect the oocyte, and for that we can thinking about future assisted conception. Then you stop the TKI at the beginning of the menstrual cycle. We start the in vitro fertilization 7 days after stop TKI, collect the oocyte, and restart after start the TKI after the collection of the oocyte. I will not read this. This is some recommendation. In this time, it's important that the patient not breast the baby 2 or 5 days after because of the colostrum, and after that you need to begin the TKI. I would like to scenario the Brazilian scenario. Then we have very, very, very challenge. This is the number of the patients in Brazil, and each year. Then, as you can see, in 2017, we had almost 20,000 patients with CML. This is the number of the new cases each year. Then, we have more than 2,000 new patients each year. Then this is a great problem, not only for Brazil, for all the countries of the world. Then we can see that this is the mortality in CML patients each year. And you can see that in 2017, less, but around 441 deaths by year. Then, with a little thinking that we can see that this is the projection about the new patients, all patients every year that is increasing. This is the rate, and this line is the mortality. This line is the new patients, and this is all the patients. And this projection, we can thinking that in 2020 we will have more than almost 25,000 patients with CML. In 2030, we will have almost 44 patients with CML. In 2050, we will have more than 70,000 patients with CML. I will not be here, but I think that this will be a great problem for us. I will ask for some cities, not so population than Monaco. They have now 30,000 patients, 30,000 population. Then we can fool 2 Monacos with these CML patients. Then this is 2050. And why this is a big problem for us, for the pregnancy, because this is the number of the patients by age in 2017 in Brazil, and we can see that more than 40,000 patients, 4,000 patients in the childbearing age, more than 2,000 women in childbearing age. This is in Brazil. The woman, they begin to be pregnant so early. Then I think about 15 years old. And this is our the group of the CML patients, of CML doctors that CML patients, CML doctors that treating patients. And I would like to thank my friends, because I received many cases Then, as you can see, we had 60 CML patients that become pregnancy. These 60, sorry for that this configuration, but 43 using imatinib, 7 using nilotinib, and 10 using dasatinib. All of them, this is as you can see that the most of the pregnancy happens when the patients were in MMR, 23 MMR, 5 MMR with nilotinib, and 6 MMR with dasatinib. We had the problems that 7 patients were pregnant when they were diagnosed with CML, and 2 patients we planned to stop the drug. This is important because in Brazil we have a great problem to monitorization. Then I would like to thank Dr. Tim Hughes and Susan, because the possibility to do less exams could insert many patients that could stop the drug, because we have this problem of we need the vouchers to monitorization the patients. Then nowadays we have many patients that they are preparing to be pregnant, and then this will be a great thing. I would like to show you that in 69 pregnancies we had 61 babies, health babies. Then this could be a very good thing. I would like to show you some publication of Brazilian doctors. This is the publication of Dr. Vanelza. She's here. Then she showed 14 pregnancies and all the good things that the patients, the most of them, the babies were healthy. And this is the publication of Dr. Mônica Conchon, using TKI, nilotinib, and dasatinib. And this is the publication of Katia Pagnano, and she showed 7 pregnancies, and all of them, the babies were healthy. I would like to show a clinical case. 24 years old patient diagnosed by CML in 2008. She had criteria to NS-stop study, then we insert her, and it was randomized in nilotinib to 800 milligrams twice a day as first line. The patient reached MMR in the first 3 months and CMR in 6 months. She used to be very adherent to the treatments. Now, in that time, using nilotinib, she without any adverse events. But in 2010, she became pregnant. In spite of to be advertised to use the contraceptive and barrier protector, she interrupted nilotinib, and it was necessary to remove her from the study. At that time, she was in complete molecular response. The patient continues in complete molecular response during all the pregnancy. Then we didn't use any drug, interferon or leukapheresis is not necessary. The baby was born healthy and term, and at that time it used to be impossible to interrupt the treatment in Brazil in the 2010, nowadays too. And was not impossible to treat CML with nilotinib, because it was forbidden at that time using nilotinib first line. Then she began imatinib after delivery. At that time I was afraid to stop completely the drug. Then I began the imatinib. After that time, she began to be no adherence to the treatment with imatinib. She didn't have any adverse events, but frequently used take the pills. She was young, then she forgot the pills, she forgot the consultation. It's a great problem. The patient continued in CMR all the time, and she confessed that she was not taking the drug during many months. The patient abandoned the follow-up in 2014, and recently, some months ago, she came back, and the PCR was undetectable. Then this patient was a great problem to me, because she used to speak with the other patients. Oh, it's not important to take the drug. My PCR is very, very good. I am in the complete molecular response. Then it's not necessary to take the pills. Then I used to take care fastly to she go away. Then this is a great problem for the adherence. Then I would like to thank my colleagues, Brazilian. This is our CML group, and this is my family. I have 6 children. It's true. Then I am the sponsor of the pregnancy. Thank you so much.